Good morning and welcome to Immunic's webcast to present and I'm very happy to say this, positive outcome of the interim analysis of our phase 3 ENSURE program of vidofludimus calcium in relapsing multiple sclerosis. My name is Jessica Brew, Vice President, Investor Relations and Communications at Immunic, and I will be the moderator for today's webcast. Speaking on the call are Dr. Daniel Vitt, our Chief Executive Officer, and Dr. Andreas Müller, our Chief Medical Officer. Please note that all participants will be in listen-only mode and this event is being recorded. During today's presentation, there will be an opportunity to ask questions. If you joined the webcast via the Zoom platform, there are two ways to submit questions. You can submit your questions in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function in the Zoom portal to queue your question. Before we begin, as always, I would like to remind you that this presentation may contain forward-looking statements. Such statements can be identified by words such as may, will, expect, anticipate, estimate, or words with a similar meaning, and such statements involve a number of risks and uncertainties that could cause Immunic's actual results to differ materially from those discussed here. Please note that these forward-looking statements reflect Immunic's opinions only as of the date of this presentation, and it undertakes no obligation to revise or publicly release the result of any revisions to these forward-looking statements in light of new information or future events. Please refer to Immunic's SEC filings for a more detailed description of the risk factors that may affect Immunic's results and these forward-looking statements. I would now like to turn the call over to our CEO, Dr. Daniel Vitt, to begin the presentation. Daniel?
Yeah, thank you, Jessica. I also would like to welcome everybody on today's call. I'm delighted to report today on the positive outcome of the IDMC meeting for the interim analysis of our ENSURE phase 3 clinical trials with a recommendation to continue the studies as planned. The ENSURE studies are twin phase 3 studies in which we are testing the activity of vidofludimus calcium in patients with relapsing MS. The studies were initiated in 2021 based on excellent phase 2 clinical trial results from our emphasis study in relapsing-remitting MS. We plan to complete ENSURE studies in 2026. Vidofludimus calcium is a first-in-class dual mode of action medicine designed to address the full spectrum of multiple sclerosis disease. Nurr1 activation provides a direct neuroprotective effect, and on top of this, the profound and selective DHODH inhibition is associated with strong effects targeting and overshooting inflammation. Vidofludimus calcium aims to be best-in-class oral DMT with an outstanding risk-benefit profile by combining strong efficacy with very good safety, tolerability, and once-daily treatment convenience. The absence of monitoring requirements during initiation or on treatment makes it an easy to start or switch to therapy. And no black box warnings or serious infections risks like PML or malignancies are anticipated based on our current data from thousands of patients and a unique mode of action. Let me now hand over to my co-founder colleague and Chief Medical Officer, Andreas Müller. Andreas, please go ahead.
Thank you, Daniel. Let me explain, first of all, good morning, everybody, and thank you for your interest in today's announcement. Let me explain a bit more about this pre-planned interim analysis of our ENSURE phase 3 program of vidofludimus calcium in relapsing multiple sclerosis. When we planned the entire program, the intent of this interim analysis was to evaluate the futility of this program in general and to investigate whether our pre-study sample size assumptions were in line with actual data. Please understand that for this interim analysis, we had to protect the blinding of the studies for Immunic and ensure the full significance level, or alpha, is still maintained for the full analysis at the unblinding of the studies in the future. This leads to some of the framework used in this interim analysis. Just a short reminder of what the phase 3 ENSURE program looks like. The program consists of two separate and independent studies with identical protocols, hence they are called twin studies by us. First of all, Immunic set the follow-up period of 72 weeks guiding efficient patient recruitment in these large placebo-controlled relapsing MS studies. Excuse me.
Bless you.
Sorry. Together with making pre-study assumptions that will be discussed later, and with a maximum follow-up period of 72 weeks, Immunic determined an anticipated sample size to power the study. For this reason, each ENSURE study was planned with a sample size of 1,050 patients, randomized 1-to-1 to 30 milligrams vidofludimus calcium and placebo. Immunic has been communicating that recruitment for the ENSURE studies is progressing according to projections. Again, this interim analysis was to reassess the required sample size for each of the studies based on data from the ongoing studies. The primary endpoint, which would be the main determinant for approval by regulatory agencies in the future, is the comparison of time to first relapse between the 30 milligram vidofludimus calcium and placebo treatment arms. Time to first relapse is a statistically efficient clinical endpoint accepted by regulators as primary endpoint in MS studies. You can think of this analysis similar to other endpoints where the results are displayed in Kaplan-Meier curves, and one could see a difference in the survival curves of the two treatment arms, and treatment effects are usually communicating as hazard ratios. We would also like to reiterate that given the mechanism of action of vidofludimus calcium with combined neuroprotective, anti-inflammatory, and antiviral properties, Immunic believes the key secondary endpoint of 12-week confirmed disability worsening is an equally important outcome to support the medical relevance of the treatment effects of this medication. This key secondary endpoint will be investigated as a pooled analysis over both ENSURE studies, which was discussed and the precondition for such pooled analysis agreed with the FDA at the start of the program. So let's talk now about the main pre-study assumptions that went into planning of the sample size for the ENSURE program. There are two main determinants that drive the statistical power of the ENSURE studies. These are the general event rate and the hazard ratio. As you're quite aware from recent study readouts, the presence of a sufficient event rate is a quite important precondition for even having the opportunity to show a potential treatment effect. We had planned for a relapse rate of 31% for placebo patients over the 27-week follow-up period. The other determinant of statistical power would be the degree of treatment effect of 30 milligram vidofludimus calcium versus placebo, commonly communicated as hazard ratio in such time-to-event analysis. The ENSURE studies were powered to detect a hazard ratio of 0.67 between vidofludimus calcium and placebo. This resulted in a required minimum of 262 first relapse events. In broad terms, the interim analysis was pre-planned to see whether these two main determinants of statistical power differ from pre-study assumptions. To do this, the relapse rates and hazard ratio were not calculated directly, but both combined are used to calculate a conditional power. Conditional power estimates the power of a study given the results observed so far and projected to the end of recruitment with certain assumptions. The calculation of conditional power and the use of it in interim analyses is quite common and well described in statistical literature. The pre-planned interim analysis was pre-planned to occur when approximately half of the planned first relapse events have occurred in the double-blind treatment period. The conditional power was only available for review by an unblinded independent data monitoring committee, or IDMC, and was used by this IDMC to make non-binding recommendations based on the preset criteria regarding futility and additional criteria to evaluate a potential sample size increase. If both criteria were not met, the IDMC would then return a response of continuous planned. I would like to reiterate again that Immunic has remained blinded during the interim analysis and has not seen any of the unblinded data and conditional power evaluations available to the unblinded IDMC to make the recommendations. Immunic has only received the recommendations from the IDMC. For question 1, the IDMC responded that the futility criteria have not been met at this time of this interim analysis in the ENSURE program. For question 2, the IDMC recommended to continue both studies as planned without recommending an increase in the sample size of either study. Of course, now everybody would like to know how we as a management team feel about this outcome of the interim analysis, and I would therefore reference the quote in our press release from this morning. We see this as a very positive event for the ENSURE program and are enthusiastic about this best case outcome of this interim analysis. With the IDMC's recommendations that the studies continue as planned without changes, we are continuing to target completion of the ENSURE studies in 2026. We believe today's result provides reassurance that the studies have the statistical power to address the primary endpoint of time to first relapse based on the original planned sample size. On this note, I would like to hand back to Jessica for her to start the questions and answer section of our webcast.
Yes, thank you, Daniel and Andreas, for presenting this positive interim outcome for our phase 3 ENSURE program of vidofludimus calcium in relapsing MS. It's time to open the call for questions from the audience, so we will now begin the question and answer session. As a reminder, if you joined the webcast via the Zoom platform, there are 2 ways to submit questions. You can either submit your questions in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function of the Zoom portal to queue your question. Our first guest today is William Wood from B. Riley. William, please unmute yourself.
Hi, yes, thank you, and good morning, and congratulations on the very nice results here. Really great to see that the progress going on. So just thinking about ENSURE 1 and 2, I mean, based on clinical trials, and then slide 3 and sort of the timing for the expected readouts, these trials look to be slightly staggered, so presumably are on at least slightly different timelines. The futility analysis occurred, though, on a pooled basis. So how should we think about these potential timing differences? And also, just as a side commentary, it seems like IDMC commented on both trials. So just any color on the potential timing differences and how we should think about these being separate but pooled trial analysis. Thank you. And then additional follow-up.
Yeah, so thank you, William. I talked about that the primary endpoint of the study, time to first relapse, is assessed per each study independently. And the second, or the key secondary endpoint, it would be the second endpoint that would be evaluated, is only done at the pooled analysis. So if the studies would read out in a staggered fashion, so this is kind of our anticipation based on the current projections of patient enrollment. But if they would read out in a staggered fashion, first of all, they wouldn't be far apart, to be quite honest. And the other thing would be that we would communicate whether the primary endpoint would be met by each of, by, for example, a study that, for example, ENSURE 1 that reads out first. And then we would wait for the key secondary endpoints, for example, to wait for the other study to complete and then assess the key secondary outcome. So I think that's the way we would handle this, because this key secondary endpoint of 12-week confirmed disability worsening requires a pooled analysis. So we would stop after the primary endpoint of the study.
Got it. And that's very helpful. I mean, just thinking about, though, the actual futility analysis, though, since it was done sort of on this pooled analysis, is it if say ENSURE 2 is slightly delayed beyond ENSURE 1, or maybe they're not delayed enough where you could be overrepresenting, say, ENSURE 1 over ENSURE 2 in your assessment?
Yes. So it is correct that there were slightly different numbers in this interim analysis contribution from ENSURE-1 and ENSURE-2, but it was not that unbalanced. And also, we had set this interim analysis to occur basically for both studies at the same time, especially for the futility analysis had to be done on a pooled basis. However, we waited until both studies had reached about approximately half of the first relapse events. So you can be assured that both studies had already reported at least half of the first relapse events for this interim analysis, which statistically then assures that the data are relevant. And that was how we planned this interim analysis, that both studies had to reach like half of the planned relapse events already.
Got it. That's very helpful. I appreciate that. And then one last one, if I may. In terms of baseline patient differences that you may be seeing, I understand that these were pooled and blinded, but maybe you could remind us any terms of patient differences or where you actually stand in terms of the full enrollment for each trial, if possible. Thank you.
Yeah, so maybe I start, William, with the last one is the easiest. We have not publicly guided to the current status of our patient enrollment, but we have guided that at least half of the relapse events have already happened in the trial that we had planned. So that will maybe give you some idea where we are. Yes, because you have to recruit patients and then give patients enough time to develop relapses in this study. And in terms of the baseline characteristics of these, we have not evaluated these two studies against each other, whether they have different characteristics. However, we really have used stratification of the randomization, both in terms of EDSS at baseline and age at baseline, which we believe that those two characteristics of patients are really driving kind of the relapse rate in patient population. So it means that it basically gives you four strata of young patients, older patients with more and less disability. And these four strata differ likely in the relapse rate that you will see. And it's very important that we make sure that they're well distributed. And with these two patient characteristics used as stratification, randomization, this very likely assures a very good distribution of these two important factors in these studies. And that's something that's the reason why we use them as stratification for the randomization in both of these trials.
Got it. Appreciate that. I'll hop back in the queue, and thank you very much, and congratulations again.
No, thank you, William, for the interest.
Thank you, William. The next one in the queue here is Matt Kaplan from Leidenberg. Matt, welcome, and please unmute yourself.
Hi, good morning, guys, and thanks for taking the questions. Just, I guess congrats on the powering assumptions that you confirmed here in the interim analysis. Can you give us a little bit more detail in terms of what the futility aspect of the analysis was in terms of the futility criteria that were examined, and how this could potentially give us a read-through for the positive outcomes of the two studies?
Thank you, Matt. Good to see you again, and good to hear you again. So we have not guided publicly exactly to the criteria, and has a little bit to do that it would enable a little bit more in terms of second guessing, I think, the interim analysis. But I think it basically, our futility criteria are set on this conditional power as well in this futility analysis. And it's a little bit more difficult to translate, for example, conditional power just in terms of hazard ratio or just in terms of relapse rate, because it takes both into consideration. But in principle, it's very close to saying, if you find that the study has almost no chances to reach a positive outcome with the current above relapse rates and hazard ratio, then basically the conditional power would be so low that we set this as futility criteria. But it's not easily translatable just into hazard ratio or just into relapse rate. Sorry, this is just a little bit more difficult than to express an equivalent of that.
Mhm. Okay, fair enough. And then in terms of the sample sizing of 1,050 patients, with the confirmation of that, I guess there was a chance that you would have had to upsize the studies. Can you give us a little bit more detail what that means in terms of not having to upsize the studies?
That's also very good questions, and we also have not guided to the criteria for the upsizing, of course. So in principle, the study, of course, was planned with which is usually done for phase 3 trial with a 90% power. So you in principle you're looking for a scenario given the current relapse rates, but also hazard ratio that maintains in that corridor of power to the end of the study. Yes, and that's more or less what the criteria have done for example, a continuous planned, and everything below this, which is kind of in these papers that we mentioned here, is basically described there how this zone below basically that value is then used to translate this into a number of patients that should be increased to maintain that 90% power calculation of the trial. So that's more or less what it is in layman's terms, like from me.
Matt, are you still with us?
I'm still there. Yes.
Yeah.
Sorry, this is probably a little bit convoluted what I'm telling you, but it's a more convoluted story, and I think really we also have basically given you all the data that we have more or less, yes, because
Yes.
the unblinded IDMC has seen a lot more data, but since we have to maintain the integrity of the trial, especially because it's a phase 3 trial, we had to make sure that we're not receiving data that would endanger basically the scientific and statistical integrity of the study.
Of course. Thank you for the added detail, and congrats on that, the outcome.
Maybe I can add one thing here, because I'm listening to the details here in our discussion, also in our presentation. The answer is basically very simple. I think it's this interim confirms that our assumptions were correct and the drug works. I think this is my conclusion from the whole analysis, and we can't look more deeper into that because that would impact the integrity of the study. So therefore, sorry to not give you more numbers and these things on these assumptions, but we also, I think, as a company, are very happy that we had the best outcome of all the options we asked the IDMC.
Thank you.
Thank you, Matt. Next one here in the queue is Faisal Khurshid from Leerink Partners. Faisal, please unmute yourself and welcome.
Hey, good morning. Congrats on the positive update. I have a couple questions. One, just on enrollment, how are things going, and do you plan to provide an estimate of when you expect to conclude enrollment?
So Faisal, unfortunately, we have not publicly guided the end of enrollment. We have publicly guided for the completion of the trials, which is, of course, somehow connected by 72 weeks and a little bit. Yes. And we have not publicly guided to the current status of our patient recruitment. But like I said earlier to William, I think if you know that the interim analysis is done, if you have basically had approximately or at least half of the events have already occurred, and that you know that you have to enroll patients and then give them time in the trial to develop these events, I think it tells you a little bit where we are with recruitment.
Got it. Understood. And then in terms of I guess the other question I have is, do you have visibility on the overall event rate? And is there anything to read into the timing of this futility analysis coming like kind of earlier in the fourth quarter rather than later in the fourth quarter, either on like what's happening in the trial or in terms of like the patient population that you've enrolled?
So if I understand well, of course, we on a blinded basis, yes, on a combined of both treatment arms, we do get updates on the relapse rates that we see, and we know the number of events. We don't know the hazard ratio. We don't know which treatment arm they belong to, but we continuously monitor the overall blended relapse rates that we have in these studies, and that's important. I think, like I mentioned, I think there were two readouts in RMS now, the last two that had really suffered from a relatively low event rate and ARR, and that makes it really, really difficult for any drug to have the opportunity to show a treatment effect. We have basically monitored this, and we believed that the overall event rate was right on basically target what we believed with the assumptions, and I told you the assumptions. You can almost calculate it from these what I gave you, if the hazard ratio is correct. So we believe that the event rate is pretty much also in line with our assumptions. You also ask about whether we know where these events coming from. So the events are basically from all of the previously enrolled patients that we have until a cutoff date, which is not that far from here, but not that far off from today. But in principle, this is all I can tell you. And there is, of course, this is a study that already is ongoing for like 2 years. So all of the countries are activated, all of the sites are activated. I don't believe there is a chance for a lot of bias between basically the period that we have used for the interim analysis and the future recruitment. But of course, this is something that we couldn't evaluate here because we are still blinded.
Got it. That's helpful. And then just last quick one I had was safety considered at all in the interim, or is safety considered by the independent committee? And do you hear back anything on that?
Yes, every IDMC meeting, whether there's an interim analysis or not, we have a lot more, is evaluate safety. This was also done. They always look at safety, and they basically, so far with all of the IDMC meetings for the Ensure, also for the Caliber meeting, have returned us continue as planned, no changes.
Great. Thank you for taking the questions.
Thank you, Faisal. As a reminder for everybody, if you have a question, please use the raise hand function of the Zoom portal or the Q&A tool. And we actually have a couple of in the Q&A tool here, and I will go through them one by one. First one is, when would you submit the phase 3 data to the FDA?
I would, at this point, we're looking towards, finishing recruitment, finishing the study. So I would not try to second guess now the exact timing of this. But of course, we're all working hard. Our whole team is working hard to finish the next milestones and complete the trials. And this is something, if you understand that both of these trials will be completed in 2026, little bit staggered, but the Ensure 2 is guided for the second half of 2026. That tells you a little bit in terms of when we could have the opportunity to really submit this to the FDA. Sorry, this is not yet completely guided for in more precision.
Thank you. Next question here is, are you in talks with a partner for marketing? How close to, sorry, there's a word missing. How close are you to an agreement?
Maybe I take over that question. So, of course, we're talking to partners, and I think this is a small world in the MS community. However, we will not give guidance of any potential deals coming, because if we have discussions ongoing, we need to maintain secrecy here in these discussions. And of course, there's more data to come in next April. So that could also be another addition to potential partnering discussions as well. So stay tuned on that end.
Next question in the queue here. Have you looked at psychiatric outcomes between the two groups?
So we have not looked at any outcomes between the two groups because I'm still blinded. So that makes it impossible. I'm very keen on a few things. As you know, we have in both last R&D days, we have discussed some of the functional outcomes, for example, fatigue. We also have, of course, some of the more psychiatric side effects as questionnaires in this studies, but there's no available data. This requires the unblinding of the trial, either Caliber or Ensure. And Caliber is the next one in April 2025. That's not that far away. And there we would have the first data. It's a different patient population. It would be a progressive MS population. But in general, I think with the previous, the understanding of MS as a disease, it's more or less seen now as a continuum between relapsing and progressive MS. So I think some of the Caliper results that we will obtain during the unblinding of the Caliper trial in April 2025 are probably also a read-through towards the relapsing MS population in a certain way.
All right, we have two more here in the Q&A tool. Active control or placebo control? Thoughts from Immunic about future question from the FDA. Won't FDA bring up this question once NDA submitted?
No. I think it's a different question on the regulatory side and on the question how good is the drug and what are the new properties, benefits for patients, for doctors, and everybody. I think first of all, I think this study is really designed to get regulatory approval, and I think that doesn't require any active comparison here. But we also want to demonstrate, and Andreas focused on that in the presentation as well. We also have this neuroprotective effect of the drug. And this is not part of the primary endpoint of the study, but this is part of the data package. It's part of the data we have generated already in the past. And we're continuing to report from the different studies. And that will help us to underline how good and how unique the drug is. And I want to remind everybody that this is not just targeting the relapses. Going beyond that, showing neuroprotection and preventing of disability worsening is one of our key goals for the entire profile of that molecule.
Thank you, Daniel. Last one here I have in the tool, and then we have one more person in the queue. Can you please clarify the 27-week follow-up period for placebo arm referenced when you explained your study assumptions?
Oh, if I had said 27, I think I must have made a horrible mistake. 72 weeks. So I hope I said 72 weeks. And if I'm not, then I apologize. So 72 weeks was basically selected towards allowing patients to basically develop enough relapses and also address, I think, the needs of a placebo-controlled trial. So I think we are very happy with that choice. I think it has turned out to be allowing us to really efficiently recruit patients into this program and at the same time basically give the patients enough time in the double-blind treatment period to develop events. So I think this was a well-balanced decision that we are quite happy about, the 72 weeks.
Thank you, Andreas. And then one more person in the queue. This is Yungo Kwak from Piper Sandler. Yungo, welcome. Please unmute yourself.
Hey, good morning, team. Can you hear me?
Yes, good morning.
Congrats on the data. This is Jung Gu on for Yaz. Could you kindly remind us which type of efficacy measures the IDMC received to make their recommendation? Besides the event rates, did they look at the effect size? And second, just to confirm, there's no alpha loss for the primary endpoint by using this conditional power estimate analysis, right?
So again, I start with the last one. There's no alpha loss, and the reason is that, and that's kind of a technical question. We only allowed for an increase in sample size to occur, and not a decrease in sample size. And that's very important for the FDA and also from the statistical point of view. So even if you would have a crazy good outcome by now, you would continue the trial. And for that reason, that we only allow the increase in sample size to occur with this interim analysis, there's no loss in alpha here. So we still maintain the statistical the significance level of 0.05 for the final analysis, which was important to us when we planned it. The other question was, sorry, now I talked too much
The
again.
type of efficacy measure.
The type of efficacy measure. So I think I pointed out in my presentation that we wanted to make sure that there's no potential to destroy the scientific integrity. So we were not doing an analysis of the primary endpoint. So there was no evaluation of the primary endpoint at this interim analysis. However, we thought we found a clever way of transforming both the relapse rate and the hazard ratio in this conditional power assumption. So that was actually developed for that reason, so that you can do an interim analysis that basically calculates the power of the study based on the current data and projecting it out to the end of the study, and allowing you to basically assess whether the current sample size and the way the study is going in terms of treatment effect allows you to maintain the required power for the primary endpoint without really evaluating the primary endpoint. And that's kind of the trick with this conditional power. So similar to what Daniel said, basically as his CEO summary, we know now that with the current rate of events that we have in the study, and with the current apparently treatment effect or effect size that we have, the conditional power indicates or seems to indicate that this basically is in line with the power assumptions for the study that we had at the beginning of the trial. And I think the CEO summary was, we know now that the drug works. I would phrase it differently from my end, but I think in principle, it's the right summary.
That was very helpful. Thank you so much.
Thank you, Jungo. We have one more in the Q&A tool, which we take as the last one for today. What relapse rate was assumed in the inclusion criteria, and are patients on any concomitant medicines?
There is no assumption of a relapse rate that we had in the inclusion criteria. Of course, you basically, when you enroll patients, you assume that they all had a relapse, for example, in a previous period as a evidence for being in relapsing MS. So that is, I think, publicly available on clinicaltrials.gov and so forth. But there's no relapse rate that we assumed other than that. So it implies a minimum relapse rate, but this is kind of normal in all of the MS trials that have been done. So now you have to help me.
The second question was the concomitant medicine.
The concomitant medication. So all of the treatment in MS, in contrast maybe to other indications, is monotherapy in terms of the disease-modifying treatments. A lot of the MS patients have symptomatic treatments that they use for fatigue, for stiffness, for all kinds of different symptoms that MS has, and those were allowed within the there are some restrictions in terms of concomitant medication that we have to highlight. However, there's very few prohibited concomitant medications with vidofludimus calcium, and that list is very, very short. But those medications are allowed, but no other disease-modifying treatments. I hope that addresses your questions.
We take it. Thank you, Andreas. Thank you for all the great questions today. This concludes our question and answer session. I would like to turn the webcast back over to Daniel for a summary and closing remarks.
Yeah, thank you, Jessica. And let me summarize what today's results mean for Immunic and vidofludimus calcium. I'm particularly excited about the positive outcome of this interim analysis, marking the successful achievement of a very important milestone for the program and the company. We are confident in vidofludimus calcium's potential to transform the oral MS market and continue to believe that the phase 3 program provides a clear and straightforward path towards securing potential regulatory approval in relapsing MS. With today's positive news, we'll now focus on completing the ENSURE studies with full steam ahead. And on top of this, our eyes are now also looking towards the next important readout in our NS program. In April, we expect to read out the phase 2b trial results from our Caliper clinical trial in patients with progressive MS. Interestingly, vidofludimus calcium could become one of the rare new medicines with the potential to target all forms of MS. And an exciting fact is that the effects in preventing progression are also important for patients with relapsing MS, even in an early stage of disease. We believe that vidofludimus calcium has the potential to fundamentally change the way we treat MS. Vidofludimus calcium is aiming to redefine the landscape of MS treatments by combining the best of two worlds, neuroprotection and relapse prevention. So far, vidofludimus calcium, as a first-in-class Nurr1 activator, has shown positive phase 2 data in relapsing-remitting multiple sclerosis, including hints to slowing down disability worsening. In addition, today's positive outcome of the interim analysis of our phase 3 program in relapsing multiple sclerosis shows confirmation that the RMS trials are on track. On top of this, positive biomarker data from our phase 2 trial in progressive multiple sclerosis obtained last year underlined the importance of vidofludimus calcium's unique dual mode of action addressing relapsing and progressive disease. Vidofludimus calcium is also easy to use. It's an important feature as well. It is a small, once-daily oral tablet, allowing easy initiation with no complex screening requirements for doctors and a unique safety and tolerability profile, including prevention of EBV, virus reactivation, and no increased infection risk observed, including no PML case reported so far. This brings us to the end of today's presentation. Thank you very much for attending, and as always, we are more than happy to answer any additional questions one-on-one.
Yeah, thank you, everybody. Thank you for joining Immunic's webcast today. The call has now concluded. You may now disconnect.